Meeting to order, please. Is there any public comment? Hearing none. Next item is human services funding, MA expansion and base funding. Who would like to address?
I think we have a bunch of things to cover. We have two scenarios essentially. One is the governor's budget is some variation, and the other is the House budget is some variation. So we're really looking at two things. Obviously, if MA expansion, I think you'll hear it as the presentation goes along, if that's pulled back or reduced significantly, along with the other cuts, we is facing a significant dilemma. If that doesn't happen, then it gives us some more breathing room. But still some challenges to face nevertheless. So who would like to do that?
I will. Doing human services first?
Yes.
Okay. Well, I put together a handout to address these issues. MA expansion in outpatient psychiatric services and partial hospitalization. That's been a real positive for mental health. It saved us approximately $100,000 of base funds. Out of those, so we could move them to other needed areas, which I'll talk about when I get to trends. Although it's really difficult, you can't project that every year. For instance, this year our extended acute care costs are much higher than anticipated because we have two individuals on the EAC who do not have medical assistance and are not MA eligible. So that has to come from base. And that service costs about $560 a day. It's a pretty expensive service. But compared to acute inpatient, it's a bargain. So, House budget, the county finance office projected about a 2.5% decrease or $211,882. It's really difficult to be able to project that because we don't know how the state is going to divvy up that money. You have the big Norristown closure and the settlement around the forensic issues. And the last I heard, the forensic lawsuit was not progressing. The lawsuit settled, but the building of services et al. Was not progressing as it's anticipated. And there was even talk about a second lawsuit in order to push that forward. So that means you have no idea what the cut will really be when it comes to the specific counties. On a real positive note for us, in fiscal year 14-15, CABHC board voted to move psychiatric rehabilitation services from base funded services to health choices funded services for folks who are health choices members. So we're starting that in July 1st of 17. We spend approximately $445,000 a year in psychiatric rehabilitation services out of base dollars. And so we do expect to see a significant savings in base dollars when that flips to health choices. Again, that's a moving target. You know, you never know if folks are going to have MA, not have MA, be eligible, not be eligible. But that's a real plus for us, especially since we've had a licensed psychiatric rehabilitation provider in our counties for many years. So the shift is not having to build a program because we already have it. So there'll be cost savings from day one around that. And there's a budget impasse. During the last impasse, we were very fortunate in that many of our big providers were able to sustain without county-based funds coming in until the impasse was over. I think we're in a real different place this year. Two of our very large providers have had major administrative leadership changes, and I'm not quite sure what the impact of that would be. During the last impasse, the Housing and Redevelopment Authority was able to sustain the impasse because they had received money that they should have received earlier in the year, at the end of the year, so they had that money there to be able to spend. They're not in that situation this year. So I think that we would be in a very different place if there's an impasse. And we would really to, we may have one, maybe two providers who could withhold some payment.
Who were the two that had the big?
So Basinger, number one, and Keystone, number two, Keystone Mental Health. Friends, we've seen a significant increase in young adults with significant trauma history and a serious mental illness. And we're in the process, which we've already started, of making some internal program revisions to an existing community residential rehabilitation program to be able to support those needs. So what, as we speak, as a matter of fact, residential staff, case management staff, social rehab staff, frontline staff workers are receiving DBT or dialectical behavioral therapy training, which is an evidence-based practice around supporting individuals with significant trauma. We've had therapists who are DBT certified, but we've not had other staff who have a real understanding of that. So what we're doing is taking the existing 2 apartments, 4 beds from one of our programs, and focusing that on these young adults. But we're not changing the program, it's just a different. And of course that will come at an increased cost because these individuals are going to require a lot more support given their trauma and self-abusive behaviors. Crisis intervention. We've seen a significant increase in unduplicated numbers of consumers served between calendar year 15 and 16. 1,649 unduplicated consumer increase between 15 and 16. Our crisis worker number has not changed. So, and in addition to that, with West Shore Pinnacle opening, crisis also then goes to West Shore Pinnacle to provide mobile services there in the ER as needed. So we've had longer waits to see crisis staff and crisis workers, as well as some longer waits to find psychiatric inpatient beds for both voluntary and involuntary commitments. The solution, well, a couple things are happening around that. One of our providers in our 5-county region, Lancaster General, is looking at developing a greatly expanded psychiatric inpatient unit. So that would certainly help with the bed shortage. One of the things though that's happening is that one of the inpatient units that's in network, not in our county, not in any of our 5 counties, but in network, who typically always had beds, is currently on suspension of referrals for performed care in county funded folks. So that
Due to capacity or due to issues?
issues, suspension of referral due to issues. Private insurance companies are still using that provider. So, okay. We've had a significant increase in waiting lists for psychiatric evaluations and therapy. Stevens Center has introduced modified open access, which has been just a godsend. What's been probably the most fascinating thing to me about that is the fact that they have about a 50% no-show rate for the open access. So, you know, we hear about this need, and here we have a provider who's doing it, and people don't show up. So that's a problem. But NHS is also has made an offer to another full-time psychiatrist that came from recruitment and retention funds from our Health Choices Reinvestment 15-16. So another full-time psychiatrist to the system would be very helpful. When that full-time psychiatrist starts, they'll go to a completely open access instead of a modified open access. Aging of the population. We're seeing an increased demand for our specialized community residences. They're the programs that serve individuals with serious mental illness and significant physical health issues. We're currently working with one of our providers to expand by 4 beds in the SCR program. So we're hopeful that that comes through. Perry County has convened a health task force with the behavioral health subcommittee to look at better meeting the needs of Perry County residents, both physical health and behavioral health. So there's a lot of things currently in process around that. And we are currently over our cap at Danville State Hospital. Technically, we have a long history of being under our cap at state hospitals. And when we closed Harrisburg, instead of the 25 beds, which we would have had allocated to us, the deal was that they would give us a 15-bed cap, which has worked great for many years because we've had 10 people there. However, when the budget, when we lost the 10% with the budget cut, our Danville population exploded to about 20. So we're at 2021. So we're over the 15 cap, but we're under the 25 cap. We did talk to the state about that. I don't know, kind of, you know, how that's going to play or not play. What that means is then that if somebody has to go to the state hospital, they're in the community longer, which drives up other costs and also takes beds away from folks who need acute psychiatric inpatient. So it's kind of a...
Is there any penalty for being over the cap?
I'm sorry?
Penalty for being over the cap?
No, they just won't take the person. Oh, there's no penalty, they just won't.
Well, so what has the state done to address the fact that, you know, we have a growing population in Cumberland County? They went from 25 to 15.
Well, at
So-
that point, that was 10 years ago.
No, that's what I'm saying. I mean,
And-
so why should our cap still be 15?
Well, that's what we talked to the state about when we met with them the other week. We talked with Phil Nader, who's head of the state hospitals, all the state hospitals, and gave him the letter that we had gotten from the state when that administration was in. So we haven't heard back yet, but we're waiting. So we're waiting to hear back from him on that, but we did talk with him about that and provide him that letter, saying, you know, that our bed cap would have been 25, and that, you know, if we needed more beds.
So what was the rationale at the time? We lost 25 beds at Harrisburg.
No, we lost,
And then it was reduced to 15.
we lost
What was-
10 beds, yeah.
Excuse me?
We lost 10.
10.
We would have had
What was the reason for?
Because we were not utilizing our beds that we had for many, many years.
Wasn't,
And we also got some resource
right,
as a
from more
result of
community
that.
basis.
Right.
Well, that's what I was
Right,
trying
so
to
we
get
got
to
some
that.
money for
That
that.
was supposedly the deal. The state was supposed to provide additional funding for community-based services for
And they did, we
for
did.
those who are in, you know, the state hospital that didn't need to be there, right?
Correct. Or that we would be able to develop programs that we could support in the community with those funds.
Okay.
Not necessarily,
It wasn't a one-for-one.
yeah.
But the fact of the matter is that there's still a need for institutional care.
Sure.
Increasingly.
And I think that there will, you know, I mean, there are some individuals who we are unsuccessful at supporting in our community. I mean, I think that that's, you know, a community function. And hopefully, as we gain more skills, we'll be able to better support some of those individuals. One of the things we're seeing in Danville that impacts the cap are those young, self-injurious individuals. We have a young lady who's been to Danville 3 times in the last several years, come back to the community and goes back to Danville. You know, in the community, you don't have the opportunities that you have in a state hospital setting to keep people safe. When you're in the community, you're in the community. And even at Danville, she actually spent more time in Geisinger Medical for self-abusive behavior than she actually spent in the state hospital. So she's back, but
How often does that happen? You have that, you know, recurrence, readmission?
Not often. Have we seen it with this population? We have very low recidivism with that specific population, the young adults. We have 2 or 3 people who are continually cycling in and out. Very specific to,
So some degree of recurrence you would be expected.
Yeah.
You would consider normal, I guess you would say, but
typically third of our citizenship is very low. It's a very difficult population. That's why we're doing all of the DBT training, to hopefully be able to sustain individuals in the community. Two other things just quick. The Housing and Redevelopment Authority are not currently issuing vouchers, new vouchers for MH. That becomes a major concern because as individuals move forward in their recovery, they will move from more intensive programs that contain a residential component to less intensive programs in the community. Many times that happens with vouchers. So without the ability to get vouchers, they would be staying in the CRR or higher level of care, which means that folks who would move into that level of care, there will not be beds for them to move into.
So first the state took away the high intensity option, and now they're gradually eroding
Yeah.
the lower intensity option.
Yeah.
So there's no option.
We just figure everybody should be getting better.
And we like that too, you know.
But then they have new people to replace them.
Yeah, that's, yeah.
Especially for
So there's that piece.
And that is the result of the president's proposed budget cuts.
Right,
And this is-
that's
and it's because of the proposed cuts
That they're waiting.
that they're trying to manage the resources that they have available, and they're not taking anybody
Right.
off the waiting list right now.
Correct.
Okay?
Oh, I
So
understand.
even a president's proposal can have an adverse impact.
That's not doom and gloom, I think there's a lot of things that we're working on, you know, to solve some of these, or to at least diminish some of the impact of these effects, but that's what's happening now.
What's really clear is what you started out with, which is that real progress you're making, let alone keeping your head above water. You pull the plug on student MA, your vote is going to take on water.
Yeah. We would have to really pull the funds from the support services to keep people healthy in the community and move them back to treatment services, which means then that you lose the support services that allow people to function in the community.
One of the things that I think that, you know, and I appreciate you using the terminology that you did about cost savings, okay? But, you know, if the MA expansion would be repealed, okay, the bottom line is that we would, you talk about cost savings of our costs and from other revenue streams, right? That MA expansion, you know, has saved those costs. But what we're really talking about is not being able to treat as many individuals in need in crisis situations with severe, you know, mental health issues. So that, you know, bottom line is what we're talking about is that people in need of these services in our county won't get the services. So then what's that mean? They end up in our jails, or they end up on the streets. So when we talk about savings, we're not really talking about savings. We're talking about the fact that these cuts and proposed cuts, whether it's the state budget or the federal budget, have very significant consequences and actually could result in increased costs
Absolutely,
to the taxpayers.
absolutely. By cost savings, what I meant was we can take those funds and use them for the DBT program and those kinds of things, which, you know, are beneficial to the community. So it's not a it's a savings in here, but we can move it here and meet some needs here. But if that goes away, we're in trouble.
Okay, you want to move on in the interest of time?
Why don't I go next, since having expansion certainly has an impact on drug and alcohol services as well. I'm going to start with the trend, and that is easy. The trend that is overwhelming our system is the same trend that we've been wrestling with for at least 3 years now, and that's the opiate health crisis epidemic that stretch our treatment and case management service system to respond to the health crisis in a variety of ways. Number one, anytime somebody needs a detox bed, it's hard to find them. So you may have noticed that we have been expanding the number of providers that we contract with for detox services, just to maximize our chances of finding a detox bed when we need it. I think we have a couple more contracts on the workshop agenda tomorrow morning, just for that very purpose. We're also very actively trying to expand our capacity to provide medication-assisted treatment for opioid dependency. And that includes methadone maintenance, the use of buprenorphine or Suboxone, and more recently, the use of Vivitrol, an injectable form of naltrexone. All different forms of MAT, medication-assisted treatment, that are considered essential strategies in dealing with somebody with an opiate addiction, particularly if they have been unsuccessful at drug-free forms of treatment. And then we've also been trying to boost recovery support services in the community, so that in addition to treatment services, we can wrap around that individual services in their home community to help them find a support group that is a good fit for them. That can help them with housing, with hunting for a job, those types of things to be able to regain normalcy and control of their life. And then lastly, a challenge that we're taking on right now, and it's a priority from our state agency, the Department of Drug and Alcohol Programs, is to establish better and tighter what is being referred to as warm handoff relationships with our hospital emergency rooms, so that those individuals who do overdose on heroin or some other opiate and survive that overdose can be intervened with, and we can make a stronger attempt, a face-to-face attempt to conduct a brief intervention and get them to take advantage of the treatment and recovery support services that are available. So that has been our effort in the past year, and will be our effort for the new fiscal year as well, to continue that work. We're able to do that to some degree, the fact that we're able to stretch our system home without new funding is because of medical assistance expansion. And I think we've mentioned that before to you commissioners, that as a result of medical assistance expansion, a number of folks in Cumberland County and in Perry County, the other county we serve, that used to depend upon us to pay for their treatment, a number of them can now access that treatment through medical assistance because of the expanded eligibility. In particular, those who fall between 100% and 138% of the formal poverty level. I shared with you a handout from the Capital Area Behavioral Health Collaborative, our CAP 5 Health Choices program. And I'll just underscore one figure for that. In calendar year 2016, individuals in that MA expansion pool accessed drug and alcohol services, the full continuum of drug and alcohol treatment services, to the tune of $1.9 million. Those are just Cumberland County residents. That's not folks on regular MA. That's just the MA expansion population. In addition to that, Perry County residents in the MA expansion pool accessed an additional 0.5 or $530,000, 0.5 million, $500,000 worth of drug and alcohol services. In the absence of MA expansion, that $2.4 million of services would not happen. Those individuals would have come to us. Our total budget is about $50 shows itself in the emergency room, it shows itself in healthcare overall, and it certainly shows itself in our prison. And it shows itself in children and youth cases, cases of neglect, child abuse, shows itself in other human services as well. So that will be a real problem if there ever is a decision to whittle away or completely reverse Pennsylvania's decision to look into MA expansion. I'll speak briefly about the state budget. Because of the opioid epidemic, the drug and alcohol funding streams were largely untouched by the governor's proposed budget, and also by House Bill 218, the House Republican alternative budget. I think nobody wanted, in the midst of an epidemic, to say, well, let's cut funding for opiate treatment. However, I don't think they realized that some of the items they did cut really do have that effect. Because when you cut other human services, the Human Services Development Fund, Homeless Assistance Money, and one big one for our county is intermediate punishment program. That's a funding stream that we have enjoyed in Cumberland County for at least 20 years. We have received funding from the Pennsylvania Commission on Crime and Delinquency to provide treatment, drug and alcohol treatment, as an alternative to incarceration for nonviolent offenders. For Cumberland County, we stand to lose $361,000 for that program. Now, some of that funding goes for treatment, some of it goes for, a good bit of it goes for case management services, and a good bit of it also goes for probation supervision. If you're going to take somebody out of prison and put them in the community, you need to have intensive supervision in order for that to be an effective alternate strategy for them. So that is the biggest concern we have from the House proposed budget.
Yeah, and I think it's important to point out too that they didn't just cut the funding, they eliminated the funding.
It's
For intermediate punishment, for adult probation, for juvenile probation services. So that tells me one thing, is they want more people to be in jail, they want to spend more money in jail.
Well,
Apparently, I mean, you know.
it completely contradicts the state's justice reinvestment initiative that has been underway for about 3 years now. And the rationale for that is really the same rationale as for these IP programs. It's to identify nonviolent offenders and give them treatment instead of jail. Because unless you address the addiction that underlies the criminal behavior, you're never going to break the cycle of repeated incarcerations.
No, that's the issue, especially with the juvenile justice system reform that we're on the cutting edge here in Cumberland County. You know, we're instituting evidence-based practices to turn young offenders around, you know, essentially so that, you know, we can reduce the incidence of recidivism, you know, so that, you know, okay, they got in trouble with the law, but they're not going to keep getting in trouble with the law. That's what these probation services are all about, is cost avoidance, and also to help people, you know, turn their lives around. So, you know, again, for those who voted in favor of eliminating state funding for juvenile probation, adult probation, and intermediate punishment, I guess they just want to see more people end up in jail.
I know that some folks have said, don't get too excited about the House budget. It's simply the next step in the process. There needed to be a vehicle for a budget, and the governor's proposal was here. This is a counter proposal, will probably end up somewhere in between. But I worry that if folks that are affected by those cuts don't speak up, that there might be a misinterpretation of the silences. Oh, I guess it's not a big deal, and we can sustain these cuts. So I do think it's going.
It's just like any other really bad negotiating strategy. You know, if you want to move it from where it is downward, you push your initial offer way back, That way, when you make a compromise, you're still cutting to what you have, which, again,
Well, if
How
the state,
responsible is that? to
if
do
the
this?
state budget, or if it passes as it was initially passed by the members of the state house who voted for it, we will see an increase in property taxes, for what in many cases are required mandated services by the state. So for those who pat themselves on the back and think this is a no tax increase budget, think again.
As we've said, the cost of government is not going down. It has to be paid for somewhere. And it's now being really has to do it. Thanks, Jack.
Thanks.
Sue, Sandy, Nick.
I can go, since we kind of, Jack already touched on the homeless assistance and HSDF, which of course is one area where we are looking at potential cuts. And ours is pretty basic. It's not a big number, but cuts would mean cuts in service. It's, a trend we've been seeing, but like with the homeless assistance program cuts, it's not just our homeless assistance where we, have the financial reimbursement to get people into apartments. But we also fund Carlisle Cares, not a lot, but it's still, every little bit counts. Carlisle Cares, Safe Harbor actually took already a cut this past year, and they're looking at another cut in this coming year. So it's just pretty basic in that whole process. Trends, obviously, homelessness is still a problem, still going to be a problem, and probably the only positive is the food banks. That money is still probably pretty, we're not talking about any cuts at the state, and a lot of that's federal money. So that's kind of the basic overview of our homeless assistance and our community service money. Aging, kind of like Jack, aging hasn't really taken a hit at the state level, but it also hasn't gone up at all. When providers want more money, obviously we have provided more personal care over the past year, personal care services in the home, with providers always asking for an increase. The state caps it at 2. We did give them a 1.5% increase for hourly rates. So obviously as costs go up, and if you have a flatline budget, we're going to have a variance there that is going to be an issue. And obviously people are getting older. We're up to about 375 people getting option services in the county, help in the home with bathing, dressing, grooming. That's been a pretty big jump this year, so that has been the increase in our services for this past year. Waiver, the trends are really, we have just a lot of unknowns in aging. Now, the assessment piece of are we going to be paid, how are we going to be paid, are they carving aging out, they still haven't figured that out yet. We've been told, we've been waiting for probably at least a year for that process. Supposedly the drop dead date now is going to be this November because Community Health Choices is coming at least to the western part of the state in January. And that's really where we are right now with readiness review. We are still on track for January of 19. So we have getting staff prepared, getting policies ready to be able to be part of that process when it arrives here. We look forward to that. Protective service is just another area as trends with older adults with mental health issues.
It's that cloud hanging.
Yeah, I know. It's just happens. and there's mental health, but dementia. It's like a real difficult issue because it's not serious mental illness enough. Sylvia and I have conversations about people that we just really don't know what to do with the times. But protective services definitely, the numbers just keep going and going. And it is mandated that we take care of people over the age of 60 who are at imminent risk. So we just don't have places for them to go. Not personal care homes, they're not always nursing home appropriate level of care, so it becomes a real difficult issue. So we always will struggle with that. And oftentimes it becomes guardianships, not something that we have to do, but what are we going to do when we have a person over the age of 60 who's at imminent risk, is not able to manage their care, and who's gonna become a guardian? So oftentimes it is us. Now, if they have money and the resources to be able to pay a private guardianship firm, that's obviously where we go after we get them through the court system. But right now, we have about 14, okay. People that we are actually serving as guardians for. So that number is remained steady. I mean, not that we've taken more, but have been able to get them into private guardianship firms. But that's just a trend. I don't know if it's a trend, but something that's obviously not going away and something that we're always struggling with. That's really, yeah. Where we are. Oh, and of course the merger is the trend, the unknown trend. I don't know if that's a trend. You're probably tired of me talking about it, but yeah, it's how will that affect? What will that mean? We don't know. I don't think the state has figured that out yet. They're just going to start with the merger and then see how things work out. It's a real concern for aging. The biggest concern being the lottery dollars, because obviously we use, most of our services are funded through the lottery, and I know that we've heard from the secretaries, Secretary Dallas and Secretary Osborne, that those lottery funds will still be used for aging, but we've already seen it eked away for long-term care services. But again, as I said, just our community services are increasing the need for community. And there's a lot of people out there who don't qualify for medical assistance, but still need help in their home. But if your income is less than $2,500 a month and you're paying rent or just to live, you don't have leftover funds for $25 an hour assistance in the home. So that's just that's kind of the missing piece of that whole process of who is going to help that middle class person who doesn't qualify for MA services. And we hope that the lottery funds stay where they belong in that process.
Yeah, I think it's going to be important to keep a close eye on that. Many years ago, over the years since the lottery was established, which is still the only lottery in the nation that exclusively benefits our seniors. So it's a benefit in that respect that, over $1 billion is generated on an annual basis to help our seniors in Pennsylvania through the state lottery. But what's happened over the years is items, services for seniors that had previously been funded out of the state general fund, have been moved. Now they're funded by the lottery. So I think what we need to keep an eye on is the reappropriation or redirection of those lottery revenues, because something's going to get hurt. Whether that's shared ride service, or whether that's the property tax and rent rebate program, or whether that's the pharmaceutical assistance. That's what's going to be important to keep an eye on. If there's an attempt to redirect those dollars from what was previously supported by the taxpayer general. So,
Yeah.
I know that's a concern.
Yes, the unknown.
And then also making sure that the seniors don't get lost in the space of this large bureaucracy.
Right.
But it's still a fastest growing segment of our population.
Silver tsunami, they like to call it. Hurricanes.
Yeah, Larry.
Hurricanes, no, come on.
Larry and I are coming right along.
Yeah, right.
Jim before me by a couple months. Sue, would you like to?
Sure. Well, I'm going to tell a little bit of a different story, so don't throw things at me. Because intellectual disabilities is slated to get money. 27 million. I know we still have 2 months to go, but knock on wood. Let's see what happens. There would be money in there for graduates. There's money in there to create a new waiver. It's called the community living waiver. It would be capped at 70,000, and it would basically help families, family support services, help individuals who want to be living in the community with supports and those kind of things. And then there's some money in there for base case management, because we're also in the renewal year for the waiver, every 40 years, states have to submit their waivers to the Center for Medicaid and Medicare Services for renewal. That is what's happening this year in the IDP world. And it's due to be approved on July 1st. And there will be many changes to the service definitions because of the changes in a lot of the federal regulations around competitive employment, segregated settings, not having people in institutions, but having them be part of their community, supporting them in competitive employment, as I already said, and also independent living. So with those kind of things happening, I need to be funded to support that. Could this all collapse? I guess it could. If there's no funding to support the new waiver, if CMS has something to say about the waiver. But as it stands, as of today, the intellectual and disabilities is to receive funding for all these new changes. Be proud. I am proud, but I'm also holding my breath. Now, for early intervention, they're pretty much stable with a modest increase. We are seeing over in Cumberland County an increase in referrals. In March itself, we had 83 referrals for early intervention, which is quite an increase. They were all appropriate referral sources. Why there were so many, I do not know, but we have seen the referrals increase for early intervention. So we have asked the state for an additional $50,000 to serve them this year and ask for it to be included in our allocation for next year as well, because the number just keeps going up. Not all of them are appropriate referrals, so not all of them get services, but because early intervention is a mandated service, when they ask for an evaluation, we have to provide the evaluation, which is, spending funds. But right now, and I'd like to see this change, we have like 60% are eligible, 40% are not. We've never been able to get a real fix on, how to make that go a different way, and have the more eligible number go up, because we have to provide the evaluation, but we do find that, some of our referrals, about 40% of them aren't eligible. But anyway, so that's the trend that we're seeing in early intervention, is more referrals, more kiddos coming for service. And we have asked for that $50,000, and they tell us we're going to get that. So I think early intervention is going to be pretty good too.
All right, well, let's go to the real glue.
Mental note, let's not go after Sue next time.
I was gonna say,
I should be over there.
I was gonna say I'll go last, but
It could all change next year.
it could.
So obviously the MA expansion, much like kind of Jack talked about, any impact to these other programs without change to any MA expansion will have a direct impact on our agency. If they, we noticed immediately more funding for people to be able to get psychiatric treatment, drug and alcohol treatment. If that would go away, that will have a direct impact on us in any manner. Looking to our budget, I did give you your lovely color charts that I make around this time of the year. So I'm going to start with these first three charts just to kind of show you where our trends are right now. So the first page is intake, and I'm kind of giving you two options to look at the chart. Remember, 2014 was our last normal year. 2015, January of 2015 would be when the laws changed. So that is when everything got turned upside down and we started to see the spike. Intake, as you can see, and even taking into account 2017, the first 3 months, we have seen a drastic increase again. So we're still climbing. Intake is not settled down. Just when we think it starts to, it just peaks on us again. You can look at that many different ways. I'm really trying to spend some time because I'm obviously preparing to begin writing the budget. So I'm really drilling down to what do we see here. And for those of you, you're aware of my staff turnover, my intake unit is my youngest staff. So they are the front line, they're the ones making those decisions, they're the ones out there doing that. And when you put all their time together right now, they have 8 months collateral, if you add up their years of service, 8 months is their average. So we're spending a lot of time with that unit, training, you know, teaming them up with experienced workers doing that. But I also think that is, we're seeing a rise because they're not connecting them to community services fast enough is what we're seeing. So that's an area that we've got to keep working on. The second page is our in-home services. And what you will see here is we actually are seeing a decrease. So we are going back down to pre-2015 levels. So at first I was excited, like, oh, yeah, I have a chart going down. But really, when you look at that, again, it's because I'm so high in the beginning, they're not connecting to those in-home services. And you'll see in the next page, they're jumping to crisis mode, which is placement type of stuff. We need to build the in-home services back up. I need to connect these families to those providers faster to not have them go into placement. Again, training, working with the staff. My middle unit's average of experience is 2 years, 3 months. But they are right now the lowest in employees. They're down 4 caseworkers in that unit.
So this, you're saying this decrease is reflected in the upward trend on the other placements?
So on the last page, you'll see placements. In March, we have officially went back over the 200 mark, with 200 children in placement. So yeah, so we're seeing that increase in intake and now that increase in placement. And what I'm correlating it to, 2 things. One, that inexperience. But if you look then, when I show you the other chart, the opiate epidemic is a direct impact to our agency recently. When you have these situations with heroin and prescription abuse in a home, it really takes away our ability to safety plan. When a whole family, when this is something that's impacting a whole family, there's not a lot of resources, which takes the child immediately into placement. So I made you this one last chart so that you could see all the years in a row. And that's kind of what my point was, so that you could see in the placement, the trend is going up. And when we drill down to those reasons for placement, parental substance abuse is our number 1.
Parental
Yes.
substance.
Parental, yes.
You just anecdotally, you can look at the newspaper articles constantly and just see the dysfunction.
OD to Chuck E. Cheese. So I'm hearing two different things. They probably aren't contradictory, but they're contrasting. On the one hand, you're sort of beating on your, I mean this in a nice way.
Right.
You're hoping that your less experienced staff will become more adept and more timely in making referrals to community resources. But you're also talking about a situation where even if your people were making things very timely and you were fully staffed and everybody had 5 years, dealing with families that more and more of whom you have to take the kids out to save them because that whole, so whatever support structure there is now gone.
Correct.
Or it's so debilitated.
Yeah. But we're working really hard. I mean, with Jack's program specifically, I mean, we have built a good warm handoff between our agencies with the recovery specialists, the substance use disorder case management side. That unit that I created and I started, it only has 2 workers. I would like to probably soon, when I'm getting full staff, turn more workers into these specialized drug and alcohol workers.
This is one of the most real things about this. And also, it's what Commissioner Hurst was talking about before with the probation department. You've got things that work. You've got more demand for those things, and now funding is being pulled. It'd be one thing if it was a total mystery, we didn't know what to do. Okay? Or if we were just wasting money on trailing the own jailing. But we have stuff that works. But the funding for it isn't there, which just, it's counterintuitive.
I would argue that the DUI IP program here in Cumberland County is a good example of that. That's been one of our most effective community corrections programs in terms of reducing the prison population. And we all know that's one of the biggest challenges facing us right now is that the prison population is starting to swell again. If the House budget goes through and that IP money is zeroed out, that will be a real problem.
Yeah, and I think the important point is, it means that more non-violent offenders are gonna end up in jail. And I mean, the whole criminal justice reform, you know, where there seems to be broad agreement, is that, you know, instead of spending all this money to house people, warehouse people in jails, that, you know, we should help, you know, to redirect those resources to, and make investments in people that work. And that's what we're talking about with the juvenile probation, is the evidence-based practices that we're, you know, and, you know, Sam Miller's saying that this is gonna gut that program, you know? So, I mean, it's just, it really is, it's counterproductive. And I'll be honest with you, I don't know that a number of our legislators who voted for it actually, you know, understood exactly what they were voting for. Or should I say what they were voting against in terms of the reduction in funding and the impact of those cuts. But I wanted to ask you just real quick, Nikki, if I'm looking at this, correct me if I'm wrong, can you explain the intake numbers?
Yes.
And the difference from 2014 to 2017? Because is that reports of child abuse? Or what is that intake number mean?
So that's the total number of reports that come into our office, yes, that are accepted for an investigation. We have two types of reports that come in, general protective services and child abuse ones, which are a numbered reports. So there's two types of report. So yes, in 2014, you know, looking at the chart without any specific.
I'm looking at March of 2014 compared to March
Yes.
of 2017, and it's more than doubled. The number.
Yes. I mean, the reporting has changed with all that training with mandated reporters. There's a big push right now, also a lot of commercials, a lot of more, it's out there a little bit more about child abuse. So yeah, we see those increases.
And it's the Sandusky without the funds to pay for it.
Without being funded.
Well, how many of these, I guess, just a follow-up question, I don't know whether these numbers are put, but are these repeat reports in
Not
some
in that
cases? These are, in other words, do we have any duplicate reports here
The only
relative to
way-
what occurred in 14, what's occurring now in 17?
There's no change in how they're counted. The way they were counted in 14, the way there aren't duplicates, but in one family could be 4 children, and you could get 4 numbered abuses because there are 4 children. But that's how they were counted in 14, that's how they're still
So
counted
we're
now.
talking
No
about
change.
individual kids?
Yeah.
Okay, wow.
Nick,
That's a
what's
big-
keeping you from getting off
I'm still struggling with civil service right now. I am sitting right now with 6 caseworker vacancies, 1 clerk, 1 case aide, and 1 fiscal. So I'm getting there, but
And I
civil
hope you
service.
know that when you
I know.
comment and just,
Yeah.
what the hell's taking so?
Yeah,
so-
I will
so-
say we were excited, we had 1 worker who left about 6 months ago, who's not happy in her new job, who wants to come back. I'd love to have her back, so I'm looking forward to that one, but yeah, we're down to 6 caseworkers, but
Probable
it
case man.
is, the civil service is a very long process for us.
Well,
That is a very long process.
So, 2 things, quick. I think we'll be meeting with HR to talk about the second wave, the don't civil service, the sequel. And we'll be in touch with you guys shortly. I think clearly, it's not just you all, but it's other people. So we'll be seeing motion on that
Good.
forward soon. Are we done? Nick?
I am.
You done?
Yeah.
I think one thing that came up in the exchange of emails, as we were getting ready for this, is the need to bring in our state reps and senators for another session at an appropriate point to convey basically the message here today to them. I wasn't all that impressed with their response the last time, but there's been some change. Representative Regan is now Senator Regan, and certainly they need to hear this, because if they don't hear it, they'll assume that everything is, those good old folks from Cumberland County are just, they're hunkered down, and I won't go any further. They're just, they're
No, and
kind of worried about it.
And I will say this, that, you know, our legislators who represent Cumberland County in the State House were given a total of 12 hours, you know, to look at the budget. The time was introduced until the time they were asked to pass it. Now, I know the argument is because this was, you know, to move the process along. But the problem is, you know, is once you establish that lower baseline, and I think you hit on it earlier, Larry, you know, now you've got to climb back, you know, and try to see whether you know, put some common sense in it. But in any event, I think you know, a session with our legislators to kind of just go over some of what we see. I think that would be helpful, and you know, give them the details that they need to take back to their leadership. To be honest with you.
That might be a good idea, but, you know, do we have time to do that based on how quickly they come here? Maybe we do that, but
We have to do it soon.
immediately send them a letter documenting our position and follow-up meeting to go over the documentation. We just send them, at least they'll read it, and we can be on record as statements of could.
Can I make a suggestion that we get the folks here, and we can all organize, get the folks here, we just present it, develop a draft for your review that succinctly makes the case and says that we'd like to see him here
Yeah.
in the good old Cumberland County Courthouse. Talk about it.
Yeah, I think sooner rather than later.
I think we can
Best-
get it.
as soon as we can, you know, get the information to them, that's fine.
I think we can have a draft in front of you this week. Watch.
No, you guys do that, I mean, very,
No,
I think that's what I know.
People have been breathing and sleeping this stuff.
Yeah, I know.
Sleeping and breathing this stuff.
Well, I think I don't know, to the extent we can do it, I know that we have, you know, these are the hard numbers. The budget was passed, sent over to the Senate, going to cut state funding in Cumberland County by $1.2 million, okay? So that's the numbers. But I think what we need to try to also show is the human side of this. And then in addition to that, if there's a way to talk about, you know, how this is actually keeping costs down. In other words, these services are actually keeping costs down or lowering what otherwise will be the cost if we don't provide these services.
Yeah.
And that, I don't know how we do that, but I mean, instead of talking about cost savings, and I appreciate your comments, Sylvia, but it's not really saving, nobody's saving anything here, all right? The question is whether or not the needs are being addressed in the most cost-efficient manner possible, all right? And, you know, some of this stuff in the House budget, it's counterproductive. It doesn't serve the needs of, you know, the most cost-efficient way of providing, you know, what needs to be done, you know? And so,
I think we can also fold in, not just human services, and Carborg is gonna get a buy on this, because she's sitting pretty. But I think we need to bring in juvenile probation and the whole prison situation as well.
Jim, exactly what you're saying, I think, is the piece of the puzzle that maybe some or all of our state reps don't understand.
no,
I mean, like you said, they had 12 hours to look at this, and it's
Yeah.
like cut, and maybe if they knew what they were doing, this cut actually is not fiscally smart to do. They maybe
Exactly.
whistle an effort
I think
too.
that's
That's the piece I think they're missing.
Yeah, I think that's.
When you have processes, methodologies, and programs that work and have proven to work, if you shortchange those programs, the system will begin to become unraveled, and the cost of dealing with it with other programs will increase. There's your first closing area. All right, so we'll have something to you by Friday. Thank you, everybody. Now the fun bunch.
We can make it quick. 'cause
This is
we've
part
covered
two,
everything. Yeah, we can make this piece quick because everybody's important information, so I'll try to look at it.
Just quickly, just the budgets, fiscal budgets are gonna go on view May 4th, and then Monday, May, with approval, June 1st, June 5th. Do you have any other questions for the human service departments? I mean, I think they covered a lot of the different topics.
How did you base your numbers? Did you use the House Republican budget, or did you use the governor's budget, or how did you come up with your?
Use historical trends.
Well, each fund probably did it different based on what they knew at the time, and we will have to adjust these budgets once the budget's approved. These are always kind of a flag. Children and youth, we use the needs-based budget. Everybody else is kind of an estimate, and we adjust as we need to.
So this is, we're going to be putting it on display, is that what we're doing?
It's going on view May 4th, is the Thursday meeting, May 8th is the Monday's meeting.
So if we have any questions?
We're also going to get you a little more of the detailed budget too. The summary sheets. Because we made more changes.
You got 12 hours to do.
We're cutting it to
Any other questions on the budget?
I'm sorry if I get a little worked up about this.
You were testifying there, Commissioner Herzler. Amen. The amen corner was rocking.
Any other business?
Yeah, can I just, after we're done, can I see everybody over in C2 for 5 minutes?
They have pilots.
No, we want to get some work done.
Whoa!
I'm just talking about that this Yes.
Is there any other business?